Welcome everybody for the last session of the day, and it's I think the most closest session to my heart. FRCS, ICO, FRCO. What are my options? We have with us faculty, esteemed faculty, Dr. Ashwin Gandhi sir, Dr. Devendra, Dr. Akshay Nair, and Dr. Rohan Sawant, all the way from London. So without much ado, I pass on the baton to Akshay to begin the proceedings.
Thank you so much, Swapnish. So we've structured the course in such a way that the 4 topics of ICO, FRCO, a clinical examination of FRCO and FRCOoph gives a very holistic, comprehensive overview. I will now present my screen. It is visible?
Yes, Akshay, it is visible. Akshay is an alumnus of Shankar Nethralaya and LBP and is an oculoplastic surgeon at Aditya Jyot and Agarwal's group of hospitals in Mumbai, a very close friend. Thank you, Akshay. Please begin.
Thanks. So in the ICO, the International Council of Ophthalmology itself conducts the examinations and offers fellowships. So why think of the ICO examinations? The first thing is that it is a very structured and objective assessment that gives you an understanding of your own knowledge level in ophthalmology. It is as any other examination, it gives you your standing amongst your peers and also gives you a recognition amongst your peers. It could possibly have better job opportunities since it could convert into a fellowship as well. And at the end of the day, some of us like to take exams. Indians in general are often give a lot of exams right from class 1 right up till ICO and FRCS. And we love 4-letter initials after our name or 3-letter initials after a name. So this could be just one more degree that we add. And more importantly, during your residency, if you take your ICO examinations, when you're paying such a huge amount of money, it is a good way to make sure that you actually end up studying. An important update is that the Royal College of Surgeons of Edinburgh have a reciprocity with the ICO since 2018. It says that the partnership between the Royal College of Surgeons and the ICO will ensure that the route from ICO to MRCS Edinburgh is seamless, and then it allows the candidate to sit for Part C of the FRCS Edinburgh, which is the highest standard of examinations for them as per what they've said. So how does this work? There is a very clear guideline that they have put up on their website where you can see that what was in 2016 FRCS in Edinburgh Part A, that along with your ICO clinical examinations and the advanced is something historical. Currently, what we are seeing is if you've taken your ICO basics and optics refraction, that is equivalent to your FRCS Part A. In addition to that, if you've taken your ICO and advanced, that is equivalent to your FRCS Part B. Therefore, you automatically are eligible for a membership of what is called the MRCS ED. In addition to that, for your FRCS, if you clear that and then do your FRCS Part C, plus 4 years of clinical practice, and then you give your Viva examination, you are then eligible for the FRCS fellowship. So it has simplified the pathways. Everything is on the ICO as well as the FRCS websites. So you can easily have a look at it online and clarify things. Coming to FICO, the fellowships. There are 3 different structures of fellowships. There is a 3-month fellowship, the 6-month fellowship, and the 1-year fellowship. So the ICO examination, your eligibility for getting through a fellowship increases if you have taken your examinations. The website says it is recommended that applicants sit for the ICO examinations. It is not an absolute compulsion because there are a few people whom we know, anecdotally, who've actually gotten ICO fellowships without taking the exams. But typically, since the denominator of people who are taking the exams is so high, they make it a point that most people who end up with fellowships are those who've taken these examinations and passed them. Before you go in to the FICO or the ICO examination route, you need to understand it is multi-stage. There is, like I said, the Part A, Part B, or the basics, the clinical sciences, and the advanced, and now subspecialty. It is an expensive route. So you need to know the pros and cons of both of this. Your advantages are that you get the post-nominal FICO to add it after your name. It helps you to navigate the FRCS pathways like I explained because of the reciprocity. And it could possibly translate to better job opportunities where people, they're becoming more cognizant of what FICO is and what the examination is. So they could obviously, understand that having cleared your ICO examinations, you are of a certain caliber. But the ICO examinations clearance is not a licensed examination. It does not guarantee that you're allowed to practice in any other country, unlike the FRCOoph or the FRCS. And ICO fellowships, again, while they give you the ICO fellowship, the utility of these fellowships, unless you really make sure that you make the best out of it, may not be that useful. And like I said, they are expensive. So that is an overview of the ICO exams. Finally, which exams do come in the ICO tree? So you have the visual sciences, which is a part A. Typically, this is conducted twice a year in March and October. It is an entry-level examination that residents typically take during their residency. 120 questions, MCQ-based questions with 4 choices, strictly based on the anatomy, physiology, the embryology, neuroanatomy, and these things. Also, there is a section on neuroanatomy, which is typically difficult for us who've forgotten anatomy of our first year. So it takes a little bit of hardcore studying. Then you have the optics and refraction, which is part B. Also conducted in March and October. Typically, part A and part B are taken together. 60 questions, again, MCQ based for 1.5 hours. Remember, if part A and B are taken together, the candidate must obtain separate passing marks for each of these two. Only then they can apply for part C. If you fail part B, then you must reappear for part B on your next attempt and clear it, and only then can you go ahead and apply for part C. Your part C is your clinical sciences. Typically, the ideal time to take this would be just after residency, because you are fresh with your knowledge from your Kansky or Parsons or whichever books you've read. 200 MCQ, single best answer. And as you can see from the list of subjects that are covered in this examination, it's more or less what you studied in your residency. Again, conducted twice a year in March and in October. The advanced examination is what is taken after residency or in fellowship, or even beyond that. It is a slightly tougher examination. It is competence and technical ability based. It does not verify training, but tests your practical competence. There are 10 extended matching type of questions and 75 context setting description, which means it could be a written or a visual or a graphical, like an OCT or a fundus diagram. And associated with that, they would give you 4 statements, and you have to choose the single best response. Now, of course, they have started a subspecialty examination, typically held in October, but for the year 2021, it may not be conducted. As of now, they have not yet announced the dates for the subspecialty examination for 2021. Essentially, you should have completed at least 1 year of clinical experience in the specialty that you're applying for. It is a 2-hour based exam with 80 context setting description. Again, with a diagram or a clinical history, you will get 4 responses, of which you need to choose the single best answer. All subspecialties will include a module on cataract. So regardless of what you do, cataract is a part of it. So those are the exams that you need to clear. And once you finish, before you get into that, you need to know what it is worth. So I've put it up in francs because this is the only thing that is not changing. The exchange rate keeps changing. At last count, it was 1,73,000 rupees. This is for your entire course. So it is prohibitive. It will only increase as time goes on, because the exchange rate is usually not in the favor of India. So that is what it takes to appear for the examinations. What do you have to read for the ICO examinations? And I know, I'll be going over it very superficially, because Devendra will be talking about this in a little more detail when it comes to the resources for the FRCS examinations. For the basic sciences and optics and refraction, the essential readings are your clinical optics by Elkington and theory of optics and refraction by Professor Khurana. They are lucid, simple, easy to understand books. For your MCQs in basic sciences, Ophthalmology by John Ferris is a standard book. The ICO of late has become well, it's been a little lazy because oftentimes we find questions from John Ferris taken verbatim with even the order of the options being the same. So this is a highly recommended book, as is the Forrester, the I Basics in Practice. For your clinical sciences, essential reading that as per what we've seen is the Massachusetts Eye Infirmary Review and Kansky. Kansky is something that I would expect almost every resident to go through cover to cover a few times during their residency. That was the cover when I was a resident. This is the cover of the book right now. And now coming to ICO fellowship. So what are the different types of ICO fellowships? There are, like I said, there are 3 month, 6 month, and 9 month fellowships. There are subspecialty fellowships focusing only on retina, uveitis, glaucoma, retinoblastoma, and ocular genetics. But overall, these are limited in the sense the fellowships are limited in number and offered only to select people who qualify for the criteria. Largely, the ICO 3 month fellowships are the ones that are chosen across multiple specialties. So these 3 month fellowships, there are almost 60 to 90 such fellowships awarded twice a year, which means there are almost approximately 120 to 180 fellowships awarded every year. With the fellowship comes $6,000 US of support grant from the ICO. You need to have completed your residency and to be a qualified ophthalmologist even before applying. So you cannot apply for this during your residency. You have to be typically below 40 years of age. They are very particular about this. And you must give them enough proof that you would be returning to your home country after your fellowship and resume your original position such that you're able to put into use what you've learned. How do you apply for this fellowship? It is a very, very straightforward process. The ICO fellowship, ICO examinations website is icooff.org. It has a 6-step process. First is you choose your fellowship, whether it's a 3 month, 6 month, 1 year, choose your subspecialty and submit your documents that prove that you are a trained ophthalmologist and qualified ophthalmologist in your country. It takes a day for them to check whether you fit their eligibility criteria and let you know. Following that, they allow you to choose the center of your choice. Depending on which country you want, you can apply. 2 things to know. You can apply to only one center at a time. And if they do not accept you, then you're allowed to choose any other center. However, once you choose in your center and they accept it, they will let you know. But if at any one point in time you fail the process of getting through a fellowship, you cannot apply again. Once rejected, the candidate cannot apply again. So you need to make sure that your file is well filled. What about you want to apply to a center that is not in the list of directory of centers? So this is something that this is a screenshot of an email that I had written to them when I applied 7 years ago for my ICO fellowship. And they said that, yes, there are, because at that time, there were not too many oculoplasty centers for ICO fellowship. And they said, if you are interested, you'll get in touch with them, let them know that you want to join. And if they're okay with you joining as a 3-month ICO fellowship, give us that letter of confirmation and we'll be able to run this eligibility check and we'll be happy to support that. So yes, they do, entertain such requests. So things that you need to consider before applying for fellowship. This is something more from my experience and applies. You need to take it on a customized basis, whether it is applicable for you or not.
Akshay, 2 minutes.
Yeah. When do you need to apply, before fellowship or after fellowship? Typically, it is better to apply after you've completed your fellowship in India, such that you're able to pick and choose what you want to learn and what you want to focus on when you're there. Is it worth it? It is absolutely worth it because it allows you to see how practice can be different and how much more you can learn. You should not treat it like any other vacation. Your contacts improve, your network improves, and it definitely adds credibility to you. And things that you should also be considered is, when should you apply? Towards the end of your fellowship in India here, or a year or two after your clinical practice here is a good time to apply. Things you need to know before applying: what are the skills and knowledge that you particularly want to acquire through this fellowship? What are you going to do with it? For example, for me, the focus was cosmetic aesthetic surgery and endoscopic surgery, skills that during my fellowship here were not that great. And finally, what are the practical implications of your fellowship when you come back here? Will you be able to, put that into practice here? If you get your answers to this, then you will be able to help well. My last couple of slides, my experience. I went as a fellow in 2015. I was able to share with them. At the same time, I had fellows from Bolivia and Spain, and my mentor there in New York, Anya Infirmary, also allowed me to visit Memorial Sloan Kettering, where I was with a week with Dr. Abramson, who's the pioneer of intra-arterial chemotherapy for retinoblastoma. Not just, we also managed to publish a lot of papers during my time there. So you should make it productive. And it is only through my ICO fellowship that I was inducted as a member of the American Society of Oculoplastic and Reconstructive Surgery. So it definitely helps. To summary, you plan well when you want to apply for the examinations and which exam when, and also your fellowship when you want to plan it. Take into consideration opinions, and all stakeholders should be involved, your family and your employers, to know how it is. Choose wisely, because these things, your ICO examination and ICO fellowship, can definitely help you build connections, build network, build skills, and eventually build your career. Chart a timeline. Don't just go blind into it. At the end of the day, having cleared your ICO examinations and an ICO fellowship is undoubtedly an asset in your practice and your reputation. So I would strongly recommend it for all trainees to think about it.
Thank you, Akshay. That was a great presentation, and we could see your illustrious career throughout those slides, and we could see that you are getting younger and younger by the years. Rashmin sir, any comments? I request Devendra to load his slide.
I think Akshay has covered it beautifully well. Just one question, Akshay, as to how did you choose your mentor? How did you choose your center?
Yeah, so I actually looked at where it was, the location, and also it's a good idea to see the list of your members in the directory. Do a PubMed search and see what are their areas of interest. That's what I did. And based on that, I could choose the area that I was looking for: endoscopic, lacrimal, and aesthetic surgery, which, as we know, is more common on the East Coast and the West Coast of USA and less in Central America, so in Central United States. So also doing a little bit of reading up and digging up on the mentors will help you realize what they are focused on, and obviously that's what you will end up seeing at their clinics.
Perfect. Thanks.
So our next talk is by Dr. Devendra on FRCS examinations, and the first slide gives away his introduction. He is a very well-known vitreoretinal surgeon at the prestigious Lakshmi Eye Institute in Panjim. Devendra, please continue.
Thanks, Swapnesh, and to the organizers for this opportunity. This is a topic that all the speakers are very interested in, and I hope it is of use to budding ophthalmologists around the country. So the Royal Colleges in the UK, I'll dive into it, are three. The Royal College of Surgeons of Edinburgh, which was established more than 500 years ago. The Royal College of Physicians and Surgeons of Glasgow, and the Royal College of Ophthalmologists in 1988. For the purpose of my talk, I'll be focusing on the first two, and Dr. Rohan Sawant, who would be joining us from the UK, will talk a little bit about the Royal College of Ophthalmologists based in London. And so practically, it's the FRCS Glasgow that is the most commonly appeared for examination. And as I said, it is a very old institution with a hoary past. And these are a few scenes of Glasgow from my visit over there when we went for the convocation after successfully clearing the examination. This is with my good friend, Dr. Asif Virani from Thane, who was my study partner. And that's a very important point I would like to make at this stage itself, that having a study partner really helps. A few glimpses of the very glamorous convocation ceremony where everyone is dressed in very beautiful robes depending on their specialty. So what are the advantages of giving the FRCS examination? Practically, there is no need to give the PLAB if you have cleared the FRCS. That means you directly apply for registration with the GMC. Comparatively, if you are an FRCS, then you have better remuneration scales or packages in the Middle East. It is accepted as a valid degree in ophthalmology in Singapore and Hong Kong, but times are changing, so I would suggest looking at the rules very closely before applying. As Dr. Akshay talked about, there's a cross exemption with ICO, And I think a lot of us, as Dr. Akshay also mentioned, like to give examinations. That was the only reason I gave the examination. As you can see, I'm very well entrenched in practice in India, and I have no intention of going either to the Middle East or the Far East. But it was just something that gave me joy of writing examinations and adding initials to your name. I don't think anybody needs to go to the extent of this great scholar of medicine, but I think it is an important factor that all of us look at, the prestige that comes with having an international degree. There are certain disadvantages. It does not really allow you to practice anywhere because it's not a licensing examination. And as with the ICO examinations, the FRCS examinations are also fairly expensive. Now, I'll give a brief overview of the FRCS Glasgow. The part 1 consists of written examination in the form of an MCQ test, which covers basic sciences and optics. Part 2 is an MCQ test as well as a written paper, which covers clinical sciences. And I think everyone would be aware that in the written paper, you have 4 essay type questions. One question is on general medicine, basically medical emergencies, and that has to be passed individually or independently before one can clear the second part. I'll be focusing my talk mainly on the structured oral examination, which forms one of the parts of part 3. This is also called the Viva. And the clinical examination will be dealt with by Dr. Ashwin Gandhi in the subsequent talk. Who is eligible for appearing for the FRCS? It depends, of course, on which part you're applying for. So in part 1, you need to have completed your internship along with 1 year of post-qualification training. And for part 2, you need to have spent at least 5 years of training post-qualification, of which 4.5 years should be in ophthalmology, essentially meaning that even a 6-month post in an allied specialty is valid as part of your eligibility. And for part 3, you just need to have completed parts 1 and 2 successfully. These are the fees as of late, but just as Dr. Akshay mentioned, these are increasing year on year. We are at a little bit of an advantage because post-Brexit, the pound has devalued a little bit. So you do get a small benefit, about 5% benefit, as opposed to if you had appeared for the examination a couple of years ago. But they are expensive examinations, and one really needs to have some financial planning apart from your academic planning in this. One can appear for each part for a maximum of 6 attempts, but I think that one would really be old and infirm if one has to depend on the 6th attempt to clear the part. So I'm sure everybody would clear it in the first or the second attempt. This is the website for the Glasgow College, and everybody can go through these guidelines on the college website. I've just taken out the main guidelines from here itself. I'll skip this because this has been covered, the ICO RCS Edinburgh reciprocity, and now the Royal College of Surgeons of Edinburgh no longer conducts examinations but depends upon the ICO ICO results to confer the degrees of MRCS Edinburgh. Now, a general principle of these examinations is that they use this technique for grading, which is the modified Angoff technique. As you can see, the pass mark, 62.21, is a very odd figure. And this pass mark is basically derived on the basis of how difficult the examination or the questions are. So it's not that 50% is a pass cutoff or 75% is a cutoff. It actually is weighed upon the number of difficult questions in that paper, and that pass mark actually fluctuates. It would be higher if the paper is relatively easy, and the pass mark would be lower if the paper is relatively more difficult. How does one prepare for these examinations? Again, this was touched upon briefly, and all examinations follow roughly the same syllabus pattern, and I can't go wrong if I recommend these 2 books, those by Elkington and A.K. Khurana for optics and refraction. Really excellent books with very different approaches, but if you are able to successfully read both of them, I think you will successfully pass part 1 without any problem. John Ferris and John Forrester, the 2 textbooks for part 1, also extensively cover basic sciences, and these are also recommended reading. For part 2, a review manual is available, the Massachusetts Eye and Ear Infirmary Review Manual, and it's an MCQ based review manual, very useful. But essentially at this stage, one would be required to read the MS and DNB syllabus, whichever one has appeared for, in great detail, because these are basically based on the clinical syllabus that all ophthalmologists would have to know. The emergency medicine question has to deal with medical situations, emergency situations like these that are mentioned over here. And the Oxford Handbook of Clinical Medicine, a little handbook, has the final section on medical emergencies with lovely flow charts. And I strongly recommend reading that and mugging up those flow charts when one appears for this part of the examination. ECG is also an important question. So just a tip is to revise yourself with common abnormal ECG patterns so as to be able to clear that. So let's see some other tips. These examinations, unlike the Indian examinations, are very practical. There is a very methodical approach that one needs to take and plan one answer. They don't really ask you for lists of conditions, but rather look at the approach to a particular clinical situation or a problem. And in general, the schema that one should follow is dealing with life-threatening conditions first, followed by those that threaten vision, and the least on that list would be cosmetic issues. So if one follows this schema, I think one cannot really go wrong. Coming to the some practical tips about the Viva, it's called this fancy name, the structured oral examination, but it's really a whirlwind which consists of these stations where you get to deal with different subspecialties of ophthalmology. And these are structured examinations because the examiner has a specific set of questions and model answers. So he really cannot ask you too much out of those specific sets of questions that are in front of him. But at the same time, neither can you answer too vaguely and expect to pass, because you really need to hit those key notes or the key words which are mentioned in the model answer for him to be able to award you those marks. In many cases, the question is in the form of a picture or a clinical situation. Pictures are in the form of a colored printout. The quality of the printout, unfortunately, may not be very good. And if it's not, the examiner will give you a hint. So don't lose your cool. That's the most important take home. Generally, the subparts of each question follow the scheme of going from an easy introductory question to more and more difficult subparts. And each of these builds on the previous answers. In other words, if you're not able to identify the condition being discussed in the first subpart itself, then the questions on the management or genetic counseling, etc., will really not be answered correctly by you either. Now, practice really pays. I think this is the single most important take home, because we are not used to performing this kind of examination in India. It's quite different from what we are used to. We have this course that we conduct at Lakshmi Institute. Unfortunately, because of the pandemic, since the last year, we have not been able to conduct it. We have esteemed faculty who are themselves examiners for the FRCs. And we go through a rigorous hand-holding of clinical examination of patients, as well as examination of clinical techniques. And I think it's quite useful to practice either in a formal course like this or one-on-one with a friend, and really go through the rigors of doing those tests and demonstrating those results for yourself. So I'll end over there. That's my email address if anybody has any questions. And I hand over to Dr. Ashwin Gandhi, who would be focusing mainly on the clinical examination and what kind of patients one can expect and questions one can expect.
Thank you, Devendra.
Welcome, Gandhi, sir. Dr. Ashwin Gandhi, as all you know, is ex-faculty at Shankar Nethralaya, and sir is now associated with CFS International. Thank you, sir, for coming and blessing us with your presence.
Thank you so much. Thank you, Swapnesh. Thank you, Dr. Lane, sir, Professor Agini, and the entire management committee for inviting me for this very nicely organized conference. Devendra and Akshay has made my job very easy. They have covered most of the aspects, and I would be giving you a little bit of introduction of what to expect once you reach the clinical examination part of FRCS, how to navigate the clinical examination part, and what are the ways by which you can prepare for these examinations. As Devendra mentioned, most of the questions that will be asked either in the Viva or in the clinical examination would be extremely clinically oriented. Unlike some of the other exams, they would not be really asking you a long list for you to rattle out, but it will be a pertinent clinical question which you'll encounter once you clear out the exam in your day-to-day practice. So what are the steps for the clinical examination? A lot of times in our busy practice, in our day-to-day life in India, we may may not give our introduction to the patient as to who we are and what we're going to do. And sometimes we skip and go directly to the examination. In FRCS, this forms an integral and important part, that you need to introduce yourself to the patient and also explain to him very briefly as to what you're going to do. Now, this requires practice, as I said, because though it should be done in our routine clinical practice, but a lot of times we skip it, maybe because of the load of patients that we see in our OPD. So this practice has to be very, very focused as to one sentence: my name is so-and-so, and I'm going to perform this examination. If you have any discomfort with the examination, let me know. Because a lot of times we see when you are told that you should introduce and explain to the patient what you're supposed to do, a lot of times candidates in the early stage would spend a lot of time in this. And you have to remember that your time is limited. You're given 20, 25 or 45 minutes. And those allotted time, you have to impress upon the examiner that you know your subject, you are able to apply the knowledge that you have gained through your reading, and that you are a safe doctor. These are very important things. You need to recollect and apply the knowledge that you learned, and to prove to the examiner that you're a safe doctor, and that has to be done. They are very, very strict with the time. Even if somebody is halfway through the question, if the bell rings, the examiner generally would avoid that question and go on to the next station. So remember this, practice how you introduce and explain as to what you're going to do in your clinical examination. The second important point is listen to the instructions that the examiner gives you very clearly, and you have to make sure that you understand what examiner has asked you to do. I'll give you an example. In clinical examination, generally, you are not given the history. You're not supposed to, or you're not expected to ask the history from the patient. You'll be given a clear instruction about performing a certain test. So examiner might ask you, demonstrate pupillary light reflex, or he may say, examine the pupils. Now these two they sound similar, but the way you begin your examination in these two instructions will be different. If examiner says, demonstrate pupillary reflex, you straight away go and perform the swinging flashlight test. If examiner, the instruction was examine the pupils, then you need to comment on the size, the other signs that might be present, and then you go on for the swinging flashlight test. So it's extremely important, because a lot of times, to save time and to give you more opportunity to demonstrate your knowledge, examiner might just ask you to say, perform swinging flashlight test or demonstrate pupillary light reflex. Patient might be having RAPD, and then you go on from there. So listen to the instructions very, very carefully. Now, carrying on with the example, if you were asked to demonstrate a pupillary light reflex, you make sure that you follow all the ideal steps, ideal test conditions which are present before you start performing the test. So in pupillary light reflex, a swinging flashlight test, as we know, you need to make sure that the room lights are off. It is performed in a dark room. So if the room lights are on, or if you're performing it in a bright room, you must politely ask the examiner to switch off the light. Make sure that the patient looks at the far object. He's not looking at you or at your torch. And then you follow the steps of a swinging flashlight test. This is extremely important. Most of the candidates, initially, if they have not practiced, they lose out. They might be knowing the subject very well. They lose out on the examination because they didn't follow all the steps, requisite steps carefully. During this examination, one of the important points is patient's comfort. And this is a joke that we repeat often. There was an examination. This is something which was passed on to us by our seniors and our examiners, that there was an exam which was being conducted in UK. A candidate was not doing too well, but as he was examining the patient, he realized the patient was feeling a little uneasy. So he stopped his examination. He inquired about the patient's health and offered him a coffee. And later on, the candidate passed. That does not really mean that you keep offering coffee every time you feel that you're not doing too well. But the whole crux of this is that you need to make sure that the patient remains comfortable all the time. So again, a lot of times by reflex, if you're seeing a patient on a sit lamp, you touch the patient, or if you're checking ocular motility, automatically our hand goes on the patient's head, and we start checking the ocular motility. Now, all these should be avoided in the FRCs exam. So If you have to touch the patient, you make sure that you do it gently. And you first say, excuse me. You don't have to explain that I'm going to touch your head. You say, excuse me, and touch the head. You don't plonk your hand on the patient's head. That sometimes we end up doing during our routine practice. Similarly, on a slit lamp examination, you make sure that if the patient is not touching his forehead on the band, you gently make sure that he touches instead of really banging his head against the hand. When you start the examination, start with a low illumination on a slit lamp or in indirect ophthalmoscope, because if the patient starts squeezing, one, you'll not get all the examination data point that you require. And second, the examiner would get that clear impression that you have not really looked after the patient's comfort very, very well. As Devendra mentioned, here also, as you start examining, you would start forming your thought and also conveying to the examiner as to what you are seeing, so that I'm performing the swing flashlight test, and on a direct illumination to the right pupil is reacting normally. When I go to the left pupil, now left pupil has started dilating. When I come back to the right pupil has started constricting, signifying that patient has RAPD in the left eye. I would like to know what the patient's vision is, whether he lost the vision acutely in the recent past. I would like to check for the color vision. I would perform the confrontation test and would like to know what the patient's visual fields are. At this point in time, the examiner might ask you to perform the confrontation test. And once you have done all that, and you'll say that I would like to check the fundus, you examine the fundus and find the disc edema in that eye, for example. So immediately you go back and tell the patient that patient has a left optic neuropathy with disc edema. He's a 24-year-old patient. And if patient has an acute loss of vision, my first priority is to rule out optic neuritis. I would like to request for MRI brain in orbit with contrast. And if if you were on the right track, if MRI has already been done, the examiner at that point in time might hand over an MRI for you to read. Most of the time, most of these examinations, there'll be a clear-cut findings. It's very rare for them to keep a finding which is very subtle or not very clear. So that's how it proceeds. You examine the patient, formulate your thoughts, convey it at the same time, and then also think about the next step. So you basically conveying your knowledge, your whatever thoughts that you have gathered to the examiner directly and live at the same time as you are examining the patient. So these are the basic steps when the patient is in front of you. Now, two very important points that you have to remember in FRCS, and as Devendra touched upon it, is that you always should remember the sight-threatening problem that might be associated with the condition that you are examining, or a sight-threatening problem that will be associated with the management of that particular condition. And the second, even important, is a life-threatening association of the condition or of the management. So for example, if you're given a patient, if you're asked to examine a patient on a slit lamp, you see a dislocated or subluxated lens, you see that patient can be having Marfan syndrome or homocystinuria, immediately you tell the examiner that my concern at this point in time is that if I take up the patient for general anesthesia and if it's homocystinuria, then they're associated with the general anesthesia risk. The second tip here is that a lot of times when you are asked that you should already tell the next steps to the examiner, we start rattling off the whole list. I would like to check the vision. I would like to check the oculomotility. I would like to check the pupil. I would like to check. Well, it has to be whatever you tell the examiner, there has to be a rationale, and probably you should tell the rationale. I would like to check the visual acuity because I expect the vision to be lower in this patient. Oculomotility, if you have a rationale. So instead of really telling the whole list, which you anyway are supposed to perform in all the patients, whatever that you tell the examiner should have a clear rationale behind it. As I said, the steps to be followed and whatever question that you are asked are generally clear-cut, but it's just that you require a little practice. Let's look at some of the examples. Now, this is one of the common patients that might be asked. You see here, patient has a little bit of ptosis and has an exotropia. You might be asked to examine this patient or demonstrate the ocular motility. And this patient actually had a recovered third no pulses. So you see there is a little bit of a ptosis here. There is exotropia, but the ptosis has improved. So it's not a complete ptosis. And this patient, the video is not playing, this patient had a very subtle aberrant regeneration. So when the patient looked down, the ptosis reduced. Now, why these patients are kept? As I said, sight-threatening and a life-threatening problem. This aberrant regeneration is a clear sign that patient might be having a compressive lesion of the third nerve, which can be because of aneurysm of posterior communicating artery, which can bleed and can lead to subarachnoid hemorrhage. Another important examination patient has both bilateral ptosis, and you will be asked to either examine the ptosis or be asked to examine the ocular motility. And you will find here that while ocular motility is being checked, patient has already developed a fatigue. There is an increase in ptosis because of fatigability. Now, why this is important? Because myasthenia gravis can generalize and can again lead to problems if it affects the diaphragm. As I said, a patient with a ptosis, and here when you see, you'll find that the pupil is involved. So you have to immediately jump saying, my immediate concern is this patient having a compressive lesion of the third nerve? I would like to perform MRI brain orbit with MRA to rule out aneurysm of the posterior communicating artery to make sure that patient is not suffering from it. So, and I'll conclude with this example that again we give quite often, that patient of thyroid-related orbitopathy is coming to you for a follow-up. He's on treatment for his hypothyroid status and he complains of cough. His endocrinologist is not in town. What would you advise to the patient? The reason why this scenario is given to the patient, to you, is because you need to know that many of these antithyroid medications can produce neutropenia, and the cough can be the first sign of that neutropenia. So instead of telling the patient that you can go away and don't worry about it, you should be aware that this can be a relatively serious problem and make sure that you order for suitable investigation. I would end here. Thank you so much, Swapnesh, and would be happy to take any questions.
Our final speaker in this session, Dr. Rohan Sawant, who was to be joining us from the UK, has unfortunately not been able to join us. So he sent a recording of his presentation, which I would play. But at this point, if there are any questions on the ICO and FRCS examinations, maybe we could cover that because his topic is on the FRCOoph examination.
I think that was an excellent presentation, and as rightly put, it is very important to have a very good body language while examination. The thought process has to be conveyed to the examiner, and the practice of how to answer in these examinations is only learned by doing it in groups or having a partner. I had a partner, Dr. Manoj Khatri, and he motivated me. Dr. Chinmay Sahu passed the exam when I was giving fellowship. So you have to find your peers who are already giving the exam, take tips from them, make them your partners while studying, and then give. In fact, I had flown back to Chennai, and a private practitioner at Egmore had spared his free time on Saturday and Sunday and trained both of us. So that's very important. Devendra, there are no questions on the chat. I think we'll move on and you can share the slide.
Okay, is it visible, the video?
Yes.
Good evening, friends and colleagues. My name is Dr. Rohan Sawant. I work as a specialty doctor on the Isle of Wight NHS Trust. At the outset, I would like to thank Dr. Rashmin Gandhi, sir, for giving me this opportunity to present in front of you. I also like to thank my dear friend, Dr. Devendra Venkatamani, who has kindly agreed for me to present my talk in proxy. My topic today is from the other side. A word about the Royal College of Ophthalmologists. It was founded in April 1988 and was slated to be considered as the voice of the profession in the UK. So how does it help? It is considered to be an exit level examination, which is a necessary but incomplete requirement to be a consultant in the UK. It now provides exemption from the PLAB exam as well. So as with every other fellowship exam, this examination also has been divided into three formats. There is a part one, there's also a refraction certificate, and a part two, which is divided into written and oral exams. Coming to the part one of the fellowship exams, a few rules. To be eligible for the exam, you don't need any previous experience in ophthalmology. The exam is based on the learning outcomes of the first 2 years of ophthalmic specialty training. In the UK, training is considered to be for 7 years, and they set out competencies based on how much needs to be achieved in terms of exams and also in terms of experience from year 1 to year 7. And for the part one, that is supposed to be achieved within the first 2 years of training. It's generally takes place about 3 sittings per year. Maximum allowed is 6 attempts. Recently, there have been changes secondary to COVID and also the way the exam is conducted. It is now a 2-hour multiple choice MCQ paper, two of those, 90 questions each, that is 180 questions in total, considered to be one best answer out of 4 options, like an MCQ exam basically. Uh, Now, from October 2020, with respect to social distancing due to COVID, it is now an online proctored exam. So you can take that exam at home or at a workplace. It is online delivered over the internet to the candidate's computer at a pre-agreed date and time. And in between the two papers, there is a 1-hour break. A typical example of an MCQ for this part, just to uh, put across the kind of level of difficulty expected. The question is, with regards to optic nerve, which statement is most likely to be correct?
I think the slides are not sharing. I'll just restart the video in a different format. Sorry about that.
So as Swapnesh and Devendra mentioned, basically all these would require a lot of practice. It's not really that we don't pass this exam because of lack of knowledge, just that we sometimes do stumble in these exams because of lack of orientation. So make sure that you have a group. There are lots of resources which are available on the website. There are lots of people now who have gone through this process, and they would be able to help, and in their courses as well. Yes, Devendra.
We don't need to have any patience, and paper is not allowed due to COVID regulations. This exam has gone fully electronic. The responses are recorded on an iPad. As there are no patients, the retinoscopies are completely simulated with a high retinoscope trainers, which have hidden trial lenses within them. This is just an OSCE sitting example. It has been just taken as a copy from the college regulations. So now we have 10 stations, in which we have 9 stations of simulated retinoscopy and 1 of photometrial lens neutralization. After part 1 and refraction certificate comes the part 2 fellowship examination. It's open after passing part 1 and refraction certificate. Previously, they had combined to 2 examinations, as in if you pass the written, you have to give the oral subsequently, and if you do not pass the oral, you have to start all over again by writing the part written again. Now they have decoupled it, thankfully. So if you pass the written, you can still have a shot or more than one shot at the oral examination. This is considered to be a synoptic exit examination that uses several different and complementary assessment methods. Again, this has been highlighted in the ophthalmic specialty training curriculum. You can find this OST curriculum on the website of the Royal College. The reasoning for testing different complementary assessment methods is they want you to know if you have the knowledge and the depth of understanding which is required for you to be an independent consultant in ophthalmology. If you're a trainee, they have to pass it before they finish the training, that's before the year 7. Maximum 4 attempts each of part 2 theory and part 2 practical. Coming to part 2 fellowship written examination, it's generally held twice a year in either June, July, one sitting, and November, December with the other sitting. Just like part 1, it can now be taken from home since December 2020. It has 2 MCQ papers, 90 MCQs in a single best answer format from an options of 4. 2 hours each paper, 1 hour break in between. Again, it's OST curriculum based. Coming to the blueprint of the examination, this is again taken from the college website. As is described, and if you look at this chart very carefully, you can see that they have made sure that you not only cover clinical ophthalmology, you also cover pharmacology, also cover investigative ophthalmology, and there are 16 questions of miscellaneous, like statistics, research, evidence-based medicine, nutrition, ethics, and a few questions of basic sciences as well. Includes genetics and a single question of optics. I'm presenting a couple of examples of MCQ just again to know what to expect. So the question goes, a 63-year-old man presented with an intraocular pressure of 23 millimeters of mercury, currently on latanoprost and timolol once daily in both eyes. He now has an intraocular pressure of 18 millimeters of mercury in both eyes with central corneal thickness of 500 microns. Optic shows cup disc ratio of 0.6 right eye, no field loss, left eye 0.9 with increasing nasal arcuate field loss. According to the NICE guidelines, and that's the reason I put this question across, CG85, what would be the most appropriate next line of management for the left eye? So you got to be well versed with the guidelines as well. In this case, after reading all 4 options, the best response is augmented trabeculectomy. Next question, 2-year-old girl referred because her mother suspects poor vision. No family history of eye problems, parents or first cousins, fundus examination is difficult because of photophobia, but you do not find any cross-retinal abnormality. ERG indicates reduced photopic ERG, normal scotopic ERG, and absent flicker ERG. What is the most likely diagnosis? The response is, given this, I don't want to test anyone's knowledge, it's just to expect the kind of difficulty of the exam. Another example of international vitreomacular traction study classification. So you should be well versed with studies and trials as well. That's the reason for this question. We'll go past it now. Regards to what you need to read. With my preparation, I can definitely say that I read these 3 books, Kanskill Clinical Ophthalmology, Oxford Handbook of Ophthalmology, and Moorfield's Manual. I found amongst all these 3 Moorfield's Manual to be very useful for theory as well as for the oral part 2 examination. There are other resources. Recently, again, Oxford Specialty Training have come up with a new book, specific MCQs for part 2 FRCOoph, and of course, the evergreen Chua website is always useful. There are a few online MCQ resources as well, iDocs and Off the Questions. Off the Questions have a particular group of questions which is specific for FRCOoph. I myself used Off the Questions when I was doing my exam and I found it quite useful. Not to forget, important Royal College of Ophthalmologists clinical guidelines which are widely used and followed within the NHS. Royal College of Ophthalmologists ophthalmic service guidelines. You can expect questions from that. NICE guidelines related to ophthalmology, of course. Another important factor is you should be well aware of the vision requirements for driving, due to which is very widely popular with DVLA, that's the Vehicle Licensing Agency. And you can also expect a few questions in the theory as well as in the oral for GMC's Good Medical Practice Guidelines. Again, these are freely available on the internet, on the GMC website. After the written comes the part 2 fellowship oral examination. You're eligible after you pass the written examination. It's again held twice a year in the UK and once a year in Singapore. Maximum of 4 attempts allowed for this examination. And the good news is once you pass the part 2 written examination, your pass is valid for 7 years. So within those 7 years, you can attempt the exam 4 times. It's divided into 2 parts, structured Viva, which generally happens on Monday and Tuesday, and OSCE, which is taking place Wednesday, Thursday, and Fridays. Of course, with Viva, it has case-based discussion of 5 stations, and the 6th station is a communication skills station. So each station lasts for about 10 minutes. I've just given you a blueprint of what they expect you to know. So the first station is has patient investigations, and you'll be given a biometry chart, for example, and they'll ask questions based on that. You'll be given an MRI or a HES chart or an electrophysiology printout, and the examiner will ask you questions. Also working with uncertainty, we're working with colleagues who can sometimes pose a problem. So these are basically guidelines which are routinely and regularly followed within the NHS. Station 2 as patient management 1. In Viva, they generally ask sight-threatening pictures or questions related to that. So they might give you a picture of anterior segment photograph and endophthalmitis and ask you about various trials, about ocular trauma and what to do in different situations. Again, the same with patient management 2, mainly emergency neuro-ophthalmic or general ophthalmic conditions. Station 4 is specific to do with attitudes, ethics, and responsibilities. For example, what you do if you suspect child abuse, consenting issues. As you read for the examinations, you'll realize that consent is done a bit differently in UK. They have consent forms 1, 2, 3, and 4. Each of them has their specific importance. Duties of a doctor regarding appraisal and revalidation, which happens every year in the UK. How to manage a complaint, how to report a critical incident, and how do you report or deal with a poor performance by a colleague. Station 5 deals with audit research and evidence-based medicine. These are again evidence-based with the guidelines pertaining to the college guidelines or NICE guidelines, so they can ask you about driving rules, medicine side effects, and how to deal with them. Station 6 is a communication skills station. It involves an interaction between a candidate and a patient, or which is an actor. It could be specific to either consent taking for cataract surgery, ptosis surgery, or you have to talk and counsel a patient. For example, if the patient is not happy with the kind of treatment that's been happened in the hospital, and also it's mainly to do with counseling and advising patients. For station 1 to 5, we'll have one examiner. Station 6 will have two examiners. One is a consultant ophthalmologist, another is a non-ophthalmic examiner. With OSCE, we'll have 5 stations, 20 minutes each. 2 examiners. Used to be 3 patients per station, now 3 videos. I'll come to that very soon. It's again highlighted in the college regulations. We have 1, 2, 3, 4, 5 stations, anterior segment, glaucoma and lit station 2, and so on and so forth. I'm presenting you with an example of videos which are now replaced patients in these examinations. Trying to see if it's working. It's probably not. Sorry about that. So as a temporary exam requirement, now because we don't have patients anymore, before the exam, your clinical skills will be assessed beforehand in a clinical setting at your local trust hospital by a Royal College appointed examiner, and they will test you for 7 clinical competencies. This needs to be done at least 2 weeks before the examination, and you'll have 3 shots of giving or passing this temporary exam requirement of clinical competencies before you actually sit for the exam. So if you give it once and if you don't go through, you can reschedule it straight away within a week or 2, and then once you get that, then you'll be eligible for the actual examination. Agreed clinical assessments are again these codes CA3, CA5, CA6, CA7, CA9, and CA10B and 10D are part of the ophthalmic specialty training curriculum. So there'll be a locally appointed examiner who will ask you questions, or there will be one of the nurses within the trust who will be used as a patient, and you have to demonstrate different skills, clinical skills basically. How to go about preparing? As you know, that's from what we have discussed in the last few slides, that WAWA is basically about clinical scenarios. OSCE is again about practice, especially with subspecialty clinics. You need to be well versed as it has been slated to be an exit level examination with different conditions of different subspecialties, and you should have a good amount of knowledge to be able to answer the questions, because the standard is set at a slightly higher standard than which is again set by the examiners, by the college. Other resources, again, I think it's a repetition of the previous slides. You should be well versed with NICE guidelines specific to ophthalmology, the Royal College guidelines, GMC documents, for example, Good Doctors, Safer Patients, they have a document of revalidation, and a general good medical practice guideline as well. DVLA related to ophthalmology, strategic papers, new studies, new trials. Sometimes they will give you an advance notification with a particular paper that you have to read for discussion at a forthcoming examination. So when patients used to be there, they expected you to have that kind of demeanor. I've taken out a few slides of this because demeanor is considered very important in these examinations. Because patients are not there anymore, that demeanor is tested at the locally taken exam by the examiner. Knowledge and conduct wise, you still need to be at the top of your game. They sometimes even check the way you sit, the way you speak, and your facial expressions. So if you don't know something, don't show that anxious expression on your face. They will then start to give you a slight negative opinion as to, oh, this person is Not knowing this, all they want to know is what are you thinking rather than what is the diagnosis. All right, last point, remember to switch the slit lamp off before you answer any questions. Useful in a clinical setting where patients used to be there. I'm hoping in the near future that they would ditch this video system and come back to real patients. Hoping for all of us. Nothing special written here. Prepare early, score well. You should make sure that you treat each patient that you see in your clinic, treat it as an exam patient, interact those kind of practices with good ophthalmic and medical care in day-to-day practice with skill examination, high level of knowledge, and safety, of course, because that is easily transferred in the examination. Good luck. If you have any questions, this is my email and this is my number as well. I'm happy to answer any questions. And again, apologize for not being present in person. And I thank Dr. Rashmin sir again and my good friend, Dr. Devendra. Good luck for exams. Thank you.
I think that was a brilliant presentation and must have motivated many of us to take up the next step, which is FRCO. Devendra, when are you giving that?
No, that's a whole other can of worms. I think, like Rohan said, and I think everybody agrees, one really has to be very sure of how one enters, because if you enter, you better well exit. It's not worth entering and not getting out of the Chakravyuh of these examinations.
Expensive Chakravyuh.
Expensive Chakravyuh, emotionally and mentally draining Chakravyuh.
I'm so happy to see Lane sir at our session.
No, I'm really missing this all, because at that time there was no Devendra, no Akshay, no Swapnesh, nobody was there to guide me. So because of that, I have not done anything. So I was just, I think, fascinating. I should have done that at time, but there was no guidance as I was in totally rural area in Ambizogai. But what I heard is, yes, such type of guidance, it was possible that time. But I think for new generation, it is a excellent opportunity. And I think the way you have put up, I think now I can tell my students that, yes, you can go ahead and you can do all these things. Thank you very much. Thank you.
Thank you, sir. Thank you. So with that, we conclude day one of the symposium and have the best of the rest of the Sunday that you had, and join again for day two, which is glaucoma and pediatric ophthalmology on the 16th of May. Thank you very much. Stay safe. And thank you, Lane sir, once again for giving all of us the opportunity.
Swapnesh, I appreciate your efforts day and night you have put in for this conference. And hard work, what is hard work, I have seen, Swapnesh, and I'm proud of you that you are my student. And really, I'm very happy that you have done such a wonderful conference. Thank you very much. My best wishes and congratulations. Thank you for everybody. Thank you very much.
Thank you.